The topic of my presentation is live donor transplantation. So we're talking about both kidney and liver live donor explantation and implantation. We'll start with the kidney and a bit of a history about kidney transplants. The first successful kidney transplant with a live donor was performed in 1954 by Joseph Murray in Boston. It was an identical twin donation transplantation, took over 12 hours. But was actually the first successful transplant. The graft lasted for almost a decade before it failed. If we look at kidney transplantation in our country, you see a lot of numbers on this slide. And the thing is that overall, approximately 1,000 kidney transplants are performed on a yearly basis, of which almost 50% are performed with live donors. And this is much more severe than in other countries. You can see that slowly we have an increase in the number of transplants during the course of the last decade. The most important thing about live donor kidney donation is that we should strive for no mortality, no morbidity in the donor, no harm to the graft that's been taken out. There should be no long-term risks for the donor and good quality of life and quick recovery after the surgery. Of course, this is not always feasible. We're still doing major surgery in the healthy person, which actually goes against the oath we take as a doctor. We're not supposed to harm anybody healthy. And there's no direct therapeutic effects for the donor. The donor doesn't benefit from donation apart maybe from the psychological benefit. The mortality rate that has been researched lately, have been shown in the literature, shows 1 to 8,000. And it's probably even lower than that. So it's already very, very low. It's in the neighborhood of being struck by lightning or hit by a coconut. The morbidity is about 2.5% during the operation and about 7% after the operation, which usually is in chronic pain. But the severity is very, very rare. The advantages of live kidney donation have mostly to do with the recipient, as the donor is the one that's has to undergo surgery for a live donation. The recipient has the benefits. So a preemptive transplant is possible if you can plan the operation just before people need to go on dialysis. And later on I will show you how important it is to prevent dialysis. There's alternative programs, so if the donor is not directly suitable, there's ways of circumventing this. So we can do ABO-incompatible transplants, paired exchange programs, unspecified donation, which is only possible if you have a live donor. The fact that the kidney is only for a very short period outside of the body means that the short ischemia time, the time the kidney is without oxygen, is very, very short, which benefits the outcome of the transplants as well. The graft function of a kidney from a live donor is superior to that of the post-mortem donor. And it also facilitates impossible transplants. So the more difficult the transplant becomes, the more important it is that we can plan the operation, get the right team, the right preparation together in order to have a successful transplant. There's also economic advantages for every transplant, for live donation in general, that if you transplant somebody successfully, overall, you save the economy about 800,000 euros per 10 years. So these are the numbers I was talking about. You can see on the left side of the slide that the graft survival of a live donor kidney is much higher than it is for a post-mortem donor kidney. And on the right side, you can see the overall adjusted graft survival, that being on dialysis actually will cost you graft survival. So if you're not on dialysis, if you do a preemptive transplant, the kidney will definitely last longer on average than if you are transplanted after dialysis, emphasizing the importance for preemptive transplant. In order to ensure donor safety and quality of life, it is very important that the donors are rigorously screened. We're looking at medical, surgical and psychological aspects, both on the short term and the long term, to ensure a very positive outcome for all live kidney donors. We have to balance absolute and relative contraindications in donation to make sure we make the right decision. It's also important that the operative techniques and training are of the highest standard, that we have a long-term follow-up, preferably lifetime follow-up, and we have safety nets in place to make sure the outcome is as best as it can be. So if we look at the surgical evolution of kidney donation, there were multiple techniques applied. In the past, like the first surgery ever done was a big flank incision, 25 centimeters, which is very painful and causes a lot of complaints in the donor. And fortunately, we progressed from 1995 to the minimally invasive techniques. There's a mini incision technique. It's still open, but a very small muscle-sparing scar. And then fully laparoscopic procedures with keyhole surgery, hand-assisted techniques, both through the peritoneum and around the peritoneum, and then robotic laparoscopic techniques. If we look at our own center, about 100% of the donors are done either laparoscopically or robotically. And robotically, it's actually laparoscopy with an extra tool to benefit the surgeon and the surgical outcome. So what does an implant look like of a live donor kidney transplantation? So it's a scar that is, the incision is made at the lower part of the abdomen. It's a semi-lunar incision. If you look at literature, they make a very large incision, but we try to minimalize it, keep it muscle sparing. So on average, in the first kidney transplant, when somebody's not too obese, you make an incision of 7 to about 15 centimeters, either in the right or the left lower abdomen. Then you look for the artery in the vein going to the upper leg, the iliac artery in the iliac vein. We make an end-to-side anastomosis of the renal vein on the iliac vein and an end-to-side anastomosis of the renal artery on the iliac artery. And after that, when reperfusion has been performed and blood is going through the kidney, we make an extravesical or Lich-Grégoire anastomosis to the bladder. There's an alternative to this technique where you don't do an end-to-side technique, but you do an end-to-end technique to the internal iliac artery, but it's really not being used that much because it's more difficult to perform and it doesn't really have any benefits. So this is an overview. I will not go into detail about how the surgery goes. I had some bloody pictures, but I took them out for the sake of people watching. And here you see that there's a small incision showing the arteries and the bladder and the way we implant the kidney. That's what I would like to tell you about the kidney transplant, and I will progress to live liver transplant. So a live donor liver transplant. The first ever liver transplant was done way back in the 60s. By Thomas Starzl, and it progressed slowly to successful living donor liver transplants in the 1990s. The technique has never stopped improving. I will show you a little bit how it goes. So the technique that we do in the Netherlands, we are in our hospital, we have done about over 60 live donor liver transplants, where we try to treat every patient that has liver disease with the technique that suits the individual patients best. By doing so many cases, we have become one of the largest live liver donor centers in the Western Europe. If you look at the global activity, this is the European activity, you see that there's only a very small margin of people actually having a live liver donor transplant. Most transplants of liver transplantation are done with post-mortem donors. And you can see in the next slide as well that the Netherlands actually has a relatively large portion of liver transplants from live donors compared to the other countries in the Eurotransplant region, which is the region we are a part of for the transplants. And you can see an increase in the number of liver transplants overall in the Netherlands, especially if you compare it to other countries. And this is partially also due to the increased numbers of live liver donors. And these are the numbers of liver transplants in the past decades, and you can see a continuous increase also facilitated by the number of live liver transplants, which is the slightly different color blue at the top. And we've already passed 100 cases a year. So what is live liver donation exactly? It is a treatment for anybody with end-stage liver disease or a hepatocellular carcinoma. And what we do is we take a healthy piece of a live liver donor and we transplant it into the recipient after removing the original liver of the recipient. The benefits are comparable to the live kidney donor transplants, where you have a younger donor, the time the kidney is out of the liver is out of the body is much shorter. It's a planned operation. It allows the recipient to avoid a lengthy waitlist stay, which usually is very detrimental to their health. And it helps alleviate the critical shortage of organs, which is also a case in liver transplant. As you can see, about 18% of patients either die on the waitlist or are removed from the waitlist because there's no livers available. And that is because there's a mismatch between the available deceased donor organs, especially in liver transplant, and the number of people on the waitlist. And that means that people are more healthy when you can transplant them, if you can transplant them sooner with a live liver donor. And being on the wait list is usually a very, very dangerous situation. The pros and cons are also comparable. Of course, if you have to operate on a live donor, it's major surgery, it will leave a scar. There's a number of complications possible during the operation, and there's also a mortality rate. But of course, the pros are, once again, more for the recipient. It's elective surgery. It does save a life. It helps the donor save a life, which can have a very positive effect on the donor himself as well. It will shorten the wait list, and it improves the survival on the wait list, and it is a better quality graft. So it functions better, just like in the kidneys, when you look at graft survival. So to be eligible for a donor, these are the eligibility criteria, and you will be screened on an individual basis to see if there's no contraindications for donation. And of course, we look at long-term and short-term outcome to see if you can go through with the operation, if the anatomy is suitable, but also if your all-over medical and psychological condition is good enough. For the recipients, there's also an eligibility criteria that you need to go through. The indications are according to international guidelines, which you see on the right here. And also there we will look at every individual case to see whether they are suitable for transplant or not. There's an extensive assessment process. I will not go through everything, but it's also done because we want to make sure that the donors have the lowest amount of risk to be able to go through the operation and the entire procedure without any serious consequences. If the donor is suitable, after we take up to 70% of the liver, which is feasible because the liver can regenerate, we have to see how big the graft needs to be. So we can take, if for example you donate to a child, you can take the left lobe. If it's to an adult, you would prefer the right lobe, and there are some alternatives that you can do, but we need to measure based on volumetrics to see if the liver is big enough for the recipient. This is what it looks like. So we will take a part of the liver either straight through the middle or just the left lateral lobe, or there's other alternatives that you can use depending on the necessity for the recipient. The surgery will be a main laparotomy, but also there's also the option of giving a robotic surgery, which I will show to you later. And what we do is we'll look at the structures that we need to save and that we need to implant. And it all looks very visible in a picture like this, but if you look at the actual graft, there's not much left, but there's still places where we can connect this liver to the recipient. As I said, we are still growing in this program. We're still doing robotic surgery for live donor liver transplant as well. So the post-operative course for a donor is that you will be on the ICU for almost 1 day, and then you can recover on the surgical ward, and on average, people can go home after a week. The recipient will be in the ICU a little bit longer, also because these patients are usually much sicker than the donors are, and they will also recover on the surgical ward, and on average go home after 2 weeks. As I said, the liver can regenerate after taking up to 70%, and this will not harm the donor. For the recipient surgery, you can see that we will implant the graft on the existing vessels you leave behind after removing the original liver. And if you see here, the top lines are the live donor liver transplants. They have a better graft survival and a better patient survival than the ones on the disease waiting list. This is probably due to the fact we can transplant earlier and they're in a better shape by the time we transplant them. So the take-home message would be that living donation has superior outcome in both liver and kidney transplantation compared to post-mortem transplant. Donor safety first is the most important thing when you talk about live donation. Innovation for the best outcomes in both liver and kidney transplant in donation and implantation is still paramount, and we are on the cutting edge of the current state of the art. Thank you very much.